Hi everyone! Today, Becca and me are going to be talking about diabetes and different kinds of it and different tests for it and how we can manage patients with diabetes. I am going to start my presentation by explaining what diabetes is. So, diabetes is a chronic, lifelong metabolic disorder in which the body either fails to produce sufficient amounts of insulin or properly use insulin at the end target organ level. Insulin is a hormone that regulates the body's metabolism of sugar by converting sugar, starches, and other carbohydrates into energy that body uses to sustain life. There are several different kinds of diabetes, and we'll discuss all of them, but the two major types are type 1 and type 2. Type 1 diabetes accounts for about 5 to 10% of all those with diabetes. It results from complete destruction of insulin-producing beta cells in the pancreas. And there's a couple of reasons for that. The first one that we know is the autoantibodies, and the other one that we don't know is the no known etiology. So people are just born with it. And type 1 diabetes results in absolute insulin deficiency that requires exogenous insulin to sustain life. People with type 1 diabetes, they're prone to ketoacidosis. And what ketoacidosis is like I mentioned above, so we use glucose to produce energy so we can sustain life. And insulin is the hormone that regulates this metabolism of glucose. So when we don't have enough insulin, our body needs to find other ways to give us some energy. So our body starts to metabolize proteins and fats. So in the end results of those metabolization of proteins and fats is ketones. Too many ketones in our body can cause acidemia and metabolic ketoacidosis, which considered an emergency because patients, they will still have a lot of glucose in their body. So they're going to have hyperglycemia and they can go into coma because our bodies, they're just not meant to have a lot of acid in our bodies. So typically, type 1 diabetes arises in childhood or adolescence. Okay, so now type 2 diabetes. Type 2 diabetes is the most prevalent form of diabetes. So it affects about 90 to 95% of all the patients. So insulin production in type 2 diabetes is minimal, normal, or excessive. So it can be either. The patient just becomes resistant to insulin and the body does not metabolize it efficiently. Patients are typically diagnosed in adulthood, but is becoming a more common diagnosis in children and adolescents due to sedentary lifestyles, poor diet choices, and obesity. Another type of diabetes is gestational diabetes mellitus. It affects about 7.1% of all pregnant women in the US. The etiology is genetics, obesity, and hormones. Women should be screened for it between 24 and 28 weeks of pregnancy. There are also several classic symptoms of diabetes, and most common of them are polyphagia, which is excessive hunger, polydipsia, which is excessive thirst, and polyuria, which is excessive urination. There is several other factors that can contribute to diabetes. So first is age, gender, ethnicity, sedentary lifestyle, diet choices, and of course, smoking. There are several diagnostic tests that we can perform to be able to see if the patient has diabetes or not. The first one is glycated hemoglobin assay, or HbA1c or A1c. A1c measures the quantity of the end product of high glucose bound to a hemoglobin molecule. And as an example, we can say that our hemoglobin molecule is a donut, and the A1c is the icing on a donut. So the higher the level, the more your donut is glazed. So A1c value provides an average of glycemia over 3 months period. So the HbA1c test is used to diagnose diabetes and prediabetes. A1c level of 5.7% to 6.4% results in prediabetes. A1c greater than or equal to 6.5% is considered diabetes. And testing is recommended twice a year for individuals with good glycemic control and every 3 months for patients with unstable glycemic control. So we also have a fasting plasma glucose test, and it's measured after fasting for at least 8 hours. So the level of 100 to 125 milligram per deciliter is considered to be prediabetes, and level greater than or equal to 126 milligram per deciliter is considered diabetes. Another test we can do is the 2-hour plasma glucose test. Typically, it's measured during an oral glucose tolerance test. The level of 140 to 199 milligram per deciliter is considered to be prediabetes, and greater than or equal to 200 is considered to be a diabetes. So, and we need to schedule a repeat testing to confirm diagnosis. So diabetes is a major systemic risk factor for periodontitis because it contributes to hyperinflammatory response to oral microbial biofilm. It impairs resolution of inflammation and repair. It delays wound healing process. It leads to accelerated periodontal destruction. And periodontitis is considered a complication of uncontrolled diabetes. So, and then Becca will talk a little bit more about other information about diabetes.
Alrighty, thank you. So, undiagnosed or poorly controlled diabetes, there has been a clear relationship established between the degree of the glycemic level, so glucose level in a patient, and the severity of periodontitis. So the higher the glucose level is, the destruction of the periodontium is going to be greater. And then the composition of subgingival microorganisms found in the oral cavity of an undiagnosed diabetic patient is similar to one that is not a diabetic patient. So we know that the microorganisms in the oral cavity don't make the patient susceptible to the periodontitis, but more so how the host is going to respond to the bacteria and the inflammation. So there has been a couple different mechanisms, 3 to be exact, that have been proposed on how the periodontium is destroyed in a patient with diabetes. So the first one's going to be hyperinflammatory response. So this is just going to, essentially there's elevated levels of tumor necrosis factors. So those pro-inflammatory cytokines or mediators, and that's just going to increase the amount of inflammation present in the patient. The second one is bone destruction and repair imbalance. So our osteoclast and our osteoblast aren't stabilized. So there's more prolonged activity of bone destruction, which is the osteoclast cells. And then there's going to be an increase in apoptosis of the osteoblasts, which are our bone building cells. So there's going to be more bone disruption and less bone building. And then the third one is going to be what we call AGES. It's this thing called advanced glycogen end product. So it's a metabolic process where the glucose is going to bind to different macromolecules or biomolecules, such as proteins, lipids, and nucleic acids. So once the glucose binds to one of these molecules, their normal functions will become destructive to the tissues of the host. In a healthy patient, there are some AGEs present, but they're not present in elevated levels, so they're not as destructive, or they're not destructive. So there's going to be 2 types of AGEs. The first one is cross-linking of AGEs, and then the second one is interaction with RAGEs. So RAGEs is going to be receptors for advanced glycation end products. So cross-linking of AGEs. This is when the formation of cross-linking of AGEs binds to collagen fibers, which collagen fibers are our repair remodeling fibers for our tissue. The collagen fibers are going to be are not going to be able to undergo the remodeling process, which is going to lead to stiffening of blood vessel walls and also loss of vascular elasticity. So it's going to impair the blood flow to the vessels or through the vessels. That's going to lead to insufficient oxygen and nutrients reaching our tissues, which can lead to major complications with an elevated level of AGEs, such as neuropathy, renopathy, and nephropathy. Then the next one, interaction with RAGEs. So this is that second kind of interaction with AGEs. RAGE is going to be receptor for advanced glycation end products. So the interaction of AGEs with cell surface receptors is going to form RAGEs. So our cell surface receptors are what allows the cells to communicate with the external environment. And this is going to stimulate the production and release of pro-inflammatory cytokines, so our tumor necrosis factor alpha, and then our interleukin 1 beta. And this is in a patient who has uncontrolled diabetes. There's going to be an overproduction of inflammatory mediators, which is going to lead to destructive effects on the host tissue. So, or other oral complications in a patient who has poorly controlled diabetes, there's going to be a reduction in salivary flow or xerostomia. So this is just going to encourage the overgrowth of Candida albicans, which can lead to candidiasis. And then also it's going to increase the risk for developing cavities. So it's going to create a good environment for carcinogenic bacteria to grow. Another thing is abscess formation. So this is going to also lead to rapid bone destruction if the patient isn't seen by a physician or is prescribed proper medications for it. Cheilitis, that's going to be the cracking or kind of just the drying out of the labial commissures, which are known as the corners of our lips. And then also burning mouth or tongue can be complications. In a patient who does have well-controlled diabetes, their susceptibility is going to be less than a patient who has uncontrolled diabetes. It also has been found out that well-controlled patients' level of diabetes is not going to make them more susceptible than a patient who is a non-diabetic. So that's good. And then interprofessional healthcare team. So this is just going to consist of physicians such as MDs, PAs, NPs, any specialists such as an endocrinologist or cardiologist, ophthalmologist, even a podiatrist, dentist, dental hygienist, and dental assistants, and then a nutritionist and pharmacist. So all these providers are going to be involved in the treatment of a patient who has diabetes. It's just going to ensure that there's constant communication, ensuring that the patient's diabetes is well controlled. And then also the patient is going to be constantly educated on the importance of maintaining their diabetes controlled for their overall health at every appointment and follow-up. Patient education. So this is our job to educate the patient every time we see them on how important it is to just maintain their diabetes and their glucose level, and also ensuring that they have very meticulous home care. So we're just going to also encourage them to seek out any medical help or treatment if they do develop a infection because of their prolonged healing time. And then as far as considerations when scheduling a patient, we're going to want to schedule the patient as early as we can in the morning once they've had their breakfast and taken their medication. We don't want to keep the patient waiting too long in the waiting room, as well as not scheduling long appointments and stressful ones. Some major signs and symptoms of hypoglycemia, which is just a drop in the blood glucose level, is going to be shakiness, dizziness, pallor or pale color, palpitations, irritability, and shakiness. And then for any medical emergency that might happen in our dental chair, we're just going to make sure our emergency kit has a glucose gel or any like quick sugars, juice, sodas, candies, that kind of stuff. And we're going to want to grab our glucometer so that we can measure what their glucose is at. If a patient does become unconscious, we're going to want to call EMS or medical services. They're going to administer glucagon intramuscularly, and then hopefully the patient will kind of come back to consciousness. And then also in a dental emergency, we're going to administer 15 to 20 grams of glucose. And then to close it out, hopefully you guys learned a little bit from the learning objectives that we had at the beginning of the presentation. Again, you can just kind of take a look at that in your own time and then go back and forth between the slides to make sure that you understand everything that we went over. We thank you for taking time, watching our video and listening to our presentation. Thank you.
Thank you, everyone. I hope you all have a good day.